and welcome to a videotape that will be teaching you the aspects of lung auscultation. There will be two components. First, figuring out surface anatomy for lung auscultation, and then actually listening to the lung sounds. This video is recreated from a previous video done by Henry Ford Hospital and the staff of Henry Ford Hospital in the early 1990s. But due to wear on the tape and the inability to see things very well, this has been recreated by graduate assistants Kim Bryce, Nadia DeDonatis, and Lee Simon. Enjoy.
So first, we'll turn our attention to the posterior of our patient. The posterior chest landmarks can be divided into three major landmarks. C7, which is the most prominent spinous process as you work your way down the back of your patient. Sometimes there will be two spinous processes which seem equally prominent, and those would be C7 and T1. The next important landmark is T3. T3 marks the major fissure which divides the upper and lower lobes in the posterior of your patient. T10 marks the lower border of the lung fields. Now this can drop down to T12 with a deep inspiration. So if we turn to our patient, if your patient is able to bend his head forward, this makes it easier to find the initial spinous process. So Lee, if you bend your head down, if you run your fingers down, you'll see this bump and you'll feel it. Now Lee only has one prominent one, so I will assume that that is C7. And you can feel your way down. This would be T1, T2, and T3. And this marks the beginning of the division between your upper and lower lobes. I'm just going to put a little mark here to show you where the lungs would go. They follow the scapula line, okay? So above this mark is your upper lobe, below it is your lower lobes. Now that I've made a mark, I just want to go back again and show you C7. Here's C7, you feel it. You feel the spinous process. This T1, T2, T3 marks the division between your upper and lower lobes. Now the lower lobes will arc to the sides behind the scapulas. As you continue to count down, this was T3, T4, T5, T6, T7, T8, T9, and T10. This marks approximately the lower border of your lung fields. Now if Lee were to take a deep breath, Lee, take a deep breath, your lung field would drop down to T12, which is about down here. Okay, so when you're listening to your patient and assessing your patient, you need to be aware that with inspiration, the lungs increase in size, and you need to assess a little bit farther down. Okay, now Lee, if you would turn around from me, Nadia will go through the anterior chest marks.
Anterior of your patient, there are a few major landmarks that you need to be aware of. One is the sternum. Everybody can feel their own sternum, and at the very top is the sternal notch. On Lee, it's right around here. As you run your fingers down your sternum, you will feel the sternal ridge or angle. That marks where your second rib attaches to the sternum, with the second intercostal space directly below that. I point this out because you need to get started on counting down the intercostal spaces. This gives you where to start, and you know this is your second rib. When counting down the intercostal spaces, it is important to move away from the sternum and count in the midclavicular line, around here. If you count close to the sternum, it's easy to lose your place. As you count down the midclavicular line to the fourth intercostal space, this marks the fissure between the right, upper, and middle lobes. If you continue counting down to the sixth intercostal space, this marks the lower border of the lung field in the midclavicular line. Now, if you were to move over to the mid-axillary line, around here, that would go down to the eighth intercostal space. So what I'm going to do on Lee is go through the markings. I had already marked the sternal notch, and sometimes on patients that are very obese or very muscular, you might have a little trouble palpating these spaces. What you need to do is palpate firmly, and once you get started, it's easy to find them. Here's your sternal notch, and as you run your fingers down, Lee has a ridge right about here. This marks the bottom of the sternum, or the sternal head, and that is also the sternal ridge or angle. As you run your finger over, here is your second rib, and right below is the intercostal space. Move away from the sternum so that you can feel more easily. Here is the third and fourth intercostal space. On the right, this marks the division between the right upper and the middle lobe, the beginning of it. The middle lobe will move over and up a little bit, and it's more of a wedge shape. As you continue to count down, here's the 4th, 5th, and 6th. This is the bottom of the lung field at the 6th intercostal space. On the left side, the upper lobe goes all the way down to the 6th intercostal space. This is because there is no middle lobe on the left side. This is important to remember because frequently when we listen to breath sounds, we tend to think of the lungs as being upper, middle, and lower on both sides of the patient. As I went through these landmarks, you can see that this is not the case. When you're assessing the front or anterior of your patient, you are primarily listening to and assessing the upper lobes with some of the middle lobe. When we looked at Lee's back, we were primarily listening to and assessing the lower lobes with some of the upper.
In the last portion of this segment, we're going to talk about auscultation. Now, when auscultating your patient, the important thing to remember is symmetry, because that's what you're comparing. So you need to make sure that when you auscultate your patient, that you do so in such a way that you can compare from one side to another.
If your patient is able to sit up, that would be the best position, upright and leaning forward slightly. Have your patient take a slightly deeper breath than normal through his mouth. If your patient is unable to sit up by themselves, you can raise the head of the bed and have someone assist the patient to a sitting position. That would be next most desirable thing. If your patient is unable to be upright for some medical condition, then it is important to assess the posterior of your patient. So you need to turn the patient from side to side so that you can listen to the back of your patient.
So Lee, I'd like you to take a slightly deeper breath than usual and breathe through your mouth. Listen to one complete breath cycle in each spot and compare from one side to another. You don't want to be directly over the scapula because the bone would decrease the sound transmission. Once you're past the scapulas, you can move over. Remember how far down the lungs go and try to assess all the way down to T12. And you need to assess the right middle lobe, so you can do it here also and listen to both sides. After listening to the posterior lung fields, then you need to listen to the anterior lung fields also. So Lee, if you could turn around, I will let Nadia take over.
It is important to remember that the apex of the lungs extends above the clavicles. So when you begin your assessment of the anterior of the patient, it is important to auscultate above the clavicles. It's frequently an area that's missed during the assessment. Okay, Lee, can you take deeper breaths than usual? As you listen to your patient's breath sounds, you will notice a change in the sound. Higher up over the main stem bronchus in this area, or in the back right between the scapulas, you will hear a much louder sound. Then as you go down over the regular lung field, the sound will be softer. This ends the portion on auscultating the patient.